Thank you very much for that kind introduction. I'm slightly amused that I'm sandwiched between a talk on vocal paralysis and medical malpractice, but I'm sure it's nothing personal. I'd like to also acknowledge the help of my fellow Christian Kamanzuli in helping me prepare for this talk, which I felt quite a tough subject, particularly when you're following Greg once again. So the talk is going to be evidence-based where possible, and I've split it up into preoperative, operative, and postoperative factors that can influence hypocalcemia and delayed discharge. I want to talk about the role of vitamin D, and particularly is there any evidence on surgical volume and whether that has an influence on hypocalcemia incidence, and about various operative factors such as technique, whether energy devices have a role in increasing or influencing the incidence of hypocalcemia, and whether visual identification of the parathyroid glands is also important. I want to touch on the controversy of autotransplantation, when we should consider that this is appropriate, and what about the influence of new technology? Does that have a possible role in influencing the incidence of postoperative hypocalcemia? What about the postoperative factors in terms of protocols, wards, early detection, intervention, again, all to facilitate the discharge of our patients? So I want to spend a little bit of time on this slide. So this is data for 1 year in England. Each point represents a surgeon, and you've got the length of stay here against the total number of thyroidectomies done by that individual surgeon, specifically for Graves' disease, which has the highest incidence of temporary and permanent hypocalcemia. The blue line is the mean stay, which is 2 days in England. And then we've got the standard deviation lines in the funnel plot at 2 and 1. And it's also important to look at this slide in terms of the structure of cost and what we get reimbursed for thyroidectomy in England. So a total thyroidectomy has a tariff of £3,500, and a 4-hour theatre list costs £5,000. So actually, to make that theatre list viable, you've got to do a minimum of 2 thyroid procedures, allowing for training and all other factors to get through that workload. Against that, you've also got to consider that each inpatient stay is £500. So if you discharge at day 2, you're essentially breaking even from a cost perspective. So only patients that stay 1 operative day, 1 night in England will actually be making money. You can see on this funnel plot that it also supports that those surgeons that are operating of lower volume have a higher spread, and there's an inverse relationship between length of stay and surgical volume. And although there are going to be other factors that will lead to delayed discharge, the vast majority, particularly in this cohort, are going to be due to calcium problems. There's an absolute plethora of literature supporting the fact that postoperative hypocalcemia increases the length of stay and therefore the costs to our institutions. So defining the issue, our 5th audit showed that the overall incidence of temporary hypocalcemia for all thyroidectomies in the UK is 23.5%. And it also showed that hypocalcemic patients at day 2 were 39% more likely to have an increased inpatient stay compared to those patients without hypocalcemia. So what can we do to avoid this? So what are the preoperative factors that may be important into actually reducing our incidence of postoperative hypocalcemia? So is hypocalcemia less of a problem in vitamin D replete patients? That everyone is vitamin D deficient in the UK. It's an expensive biochemical test, and it's not recommended that we routinely test it prior to thyroid surgery. But does preoperative vitamin D loading reduce hypocalcemia? And again, there's lots of evidence that making the patient vitamin D replete prior to surgery does have a positive influence in decreasing the incidence of hypocalcemia and therefore reducing length of stay. So all of our patients are routinely vitamin D loaded. We give them 20,000 units of active vitamin D3 weekly until the time of their surgery. What about the volume? The first slide did support other speakers during the conference that volume and outcome do have a correlation. And there's plenty of literature evidence showing that postoperative hypocalcemia, when operated by high-volume surgeons, is less. And high volume in the literature is defined as a surgeon performing between 40 to 50 thyroidectomies a year. In the UK, there are very few surgeons that perform over 100 thyroidectomies a year, and I think one of the speakers yesterday showed that the incidence of complications is decreased right up to about 100 cases per year. So volume and outcome do have an important role to play, and therefore it has a negative effect on early discharge and is also a factor that we should be looking at to improve the cost and experience of our patients. I couldn't find any evidence in the literature specifically looking at surgical technique and whether that has a factor in leading to postoperative hypercalcemia. But standard practice is clearly to try and perform an intracapsular dissection, and this is for the trainees, not the experienced surgeons here, so that you are preserving the blood supply of the parathyroids. And although that is predominantly from the inferior thyroid artery, is clearly also an important supply from the superior thyroid. And that's why the literature shows that if you actually divide the trunk of the inferior thyroid artery, then that doesn't actually influence the incidence of early hypercalcemia. But it would not be good practice generally to actually achieve that. But if you are finding the nerve low and therefore skeletalize it over a period of length, not only do you run the risk of actually traumatizing that nerve, but you also increase the risk of devascularizing or removing the main supply of the parathyroid glands. So it is the parathyroid glands that I'm more concerned about when performing thyroid surgery than the actual recurrent laryngeal nerve. And my practice is to find the nerve high and late rather than low. And I try and minimize the dissection of the recurrent laryngeal nerve, but by doing that, I also can ensure that I'm not damaging so many of the small fine vessels that obviously supply the parathyroid glands. But I could find no evidence, once again, that technique was associated with a variability in the incidence of hypercalcemia. Most of us in the West world will use energy devices. Does this increase the incidence of hypercalcemia by leading to heat transfer? There seems to be no evidence that using the energy devices like ligature compared to the standard old techniques of ligation and tying increases the incidence. And that applies to all of the energy devices, including the harmonic, the ligature, and the plethora of other devices that are presently extant in surgical practice. What about surgical technique? Well, direct parathyroid visualization has been regarded as the gold standard. And we know that the identification and preservation of at least two glands is paramount because we do not see hypercalcemia in patients that just have a thyroid lobectomy. But there is also evidence of higher calcitonin when all four parathyroids are deliberately identified and dissected. So if you can't find the four parathyroid glands, it is recommended on the basis of evidence that you shouldn't go and search for the fourth gland when performing thyroid surgeries. That does seem to have an increased incidence of hypercalcemia as shown in the literature. What about autotransplantation? Well, we know autotransplantation works when there are drivers. So Sam Wells, some years ago, showed that in secondary hypoparathyroidism, in renal disease, then auto-transplanted parathyroids will take when they're in a vascularized bed within the forearm. But the evidence for and against, as you can say, is controversial. There's a paper, as you can see in 29, showing that there is evidence that it works. And these are two papers of many papers within literature supporting the fact that routine autotransplantation does actually work. But probably the one paper I would recommend you reading is Antonia Sitges-Serra from Barcelona, whose paper gives support that it does not work. So I think on the basis of the evidence, it would appear that certainly autotransplant, if you actually find the parathyroid on the specimen, because inadvertent parathyroidectomy occurs in about 10% of total thyroidectomy. So examine the specimen and autotransplant. But if the parathyroid gland is viable, then you shouldn't routinely take a viable gland and auto-transplant on the hope that's going to decrease long-term incidence of hypoparathyroidism, and it's certainly going to increase the incidence of temporary hypercalcemia and therefore delay patient discharge and increase patient stay. What about technology? Is that going to play a role for us? So what about autofluorescence? Well, the parathyroid glands have a natural ability to autofluoresce, and the mechanism of how that is achieved is unknown. It's thought to be possibly due to the fact that there are molecules within the mitochondria, and we know that parathyroids are rich in mitochondria, and that is responsible for the autofluorescence. And it will autofluoresce to a factor of between 2.5 and even as much as 9 compared to background tissue. So there are static and dynamic methods of autofluorescence. So Fluoptics on the second floor here, I'd recommend that you go and see their device. So it essentially works by shining narrowband infrared wavelength of approximately 785 nanometers to the tissues, and then that natural autofluorescence of the parathyroid is then picked up in the camera. But of course, if you take the parathyroid out of the patient, it's therefore devascularized, it will still autofluoresce. So although it will help you identify the parathyroid, it doesn't actually tell you whether it's still viable in terms of its vascularity, in terms of its arterial and venous supply. So that's one of the static methods that is presently available. And what about the dynamic? You can actually put indocyanamine, and after 3 or 4 minutes, the parathyroids will take this up selectively, and that will clearly show that at least there's an arterial supply to the parathyroids. But what we need a system where not only it will light up with the indocyanamine, but over a short period of time, a few minutes, we'll actually see a decrease in that natural autofluorescence. So we know that the vein side of the perfusion is also working. And I think this is probably going to have value. It clearly needs to be validated. And I know Medtronic are presently also buying a system which hopefully, provided that we can get this validated and standardized, will have value in allowing us to decide as surgeons whether a parathyroid is viable or non-viable, because I think we're not very good at that. It's very difficult, even for experienced surgeons, to actually tell and make an accurate assessment of the viability of an individual parathyroid. Upstairs, there's also the parathyroid eye pin. This also works by shining, again, this near-infrared wavelength onto tissue. It's a disposable probe, and then it converts it to an acoustic signal. This is obviously a lot cheaper than the present systems that are also around, and I think this may also have value. Other devices are electric impedance spectroscopy, which is a handheld device to differentiate parathyroid from non-parathyroid tissue. And finally, there's even a technique known as confocal microscopy, and this allows you to differentiate parathyroid cells from fat cells, and you can even see the blood vessels actually perfusing the parathyroid tissue. This has only been used at an experimental level at the present time. In terms of the postoperative factors, and this is where a designated ward is very important. We know that early calcium and PTH measurement will give us a gold standard in terms of predicting early hypocalcemia, and then therefore early intervention will facilitate patient discharge. But if you do not have the facilities to measure PTH, as calcium can take some time to drop, just look at the phosphate, because if the patient's becoming hypoparathyroid, then what you will see as an early marker will be a rise in the phosphate level. It's a very, very accurate and specific indicator of hypercalcemia, particularly if the patient's vitamin D replete. So protocols, very, very important. This is our protocol, so we routinely will give 1 gram of calcium at 6 p.m, 8 a.m. next morning, we'll do the calcium and PTH at 9 p.m, and the following morning. And what you'll notice from the protocol is that we very rarely, if ever, give intravenous calcium, which is quite a dangerous thing to do. So you've really got to detect this early and intervene early. And by having protocols, we've got some very good surgeons in London, some of them are in the audience, but it has enabled us to have a 1/3 inpatient stay compared to the other units within the M25 or within London. And that's not because we're better surgeons, clearly. It's because I think we have a designated ward and we intervene early, and we have a protocol, and we manage these patients aggressively. What about artificial PTH? Well, whether it's the 84 or the 34 amino acid chain, it's either 1 or 3 injections a day. It's expensive. I think the endocrinologists have an opinion that it's good for osteoporosis, but generally not very good for routine thyroid surgery. It may have a role when there's an inability to absorb calcium and vitamin D from the gut, if the patient's had bariatric surgery, for instance. But there is level 1 evidence that obviously it does have a use or a role to play in those patients that are particularly refractory to their hypercalcemia treatment, and therefore facilitating early discharge. But we've never had any patients that we've not been able to control with refractory hypercalcemia on anything other than vitamin D and calcium. So the evidence in conclusion is that vitamin D is important, so vitamin D load your patients, make sure their vitamin D replete. It's important to consolidate hospital expertise and not having too many people within your hospital perform thyroid surgery, because as you can see, there's very, very good evidence that volume does influence outcome and therefore negatively influence length of stay. Although there's no evidence, I think standard practice is to perform an intracapsular dissection technique to preserve the vascularity of the parathyroids. You should handle the parathyroids with a non-touch technique with meticulous handling. The ligature and other energy devices are just as safe with regard to parathyroid viability as compared to the standard ligature. And don't search for glands if you haven't seen them, because there's also evidence to show that increases the risk of hypocalcemia and therefore delaying discharge. Don't transplant healthy viable glands, but always check once again the specimen for parathyroid tissue, because inadvertent parathyroidectomy occurs in about 10% of thyroidectomies. At the moment, there's low evidence for new technology, but I have to say, from what I've seen, there's promising advances happening in technology that may actually help us determine about the viability of parathyroids, and this may also have value, therefore, in allowing us to decide whether a gland should or should not be auto-transplanted. And that may have value, therefore, in preventing long-term permanent hyperparathyroidism, although clearly it's going to increase short-term hypercalcemia. But at least we can predict it and therefore treat it more aggressively. And finally, the nursing environment team. We have a 48-hour directive in Europe, so we don't have much continuity with junior staff now. So having them in a designated ward environment, having designated protocols that the trainees can refer to is very, very important. So we detect hypocalcemia early, we can intervene early, and that will again promote discharge. Thank you very much.
So it appears that our medical malpractice lecture is not going to take place. I know that everybody's looking forward to that. But since we have two experts in the field and we have 15 minutes, if it was okay, I was going to invite them to come to the stage and then open it up for questions. And then I did want to let people know that after this, there's going to be a panel. And so we'll have a group of experts that are also going to talk about surgical complications. But if you two wouldn't mind coming up, and we'll open it up to the audience for any questions for these two experts. Okay, so we have a question in the back.
Hi, I'm Fernando Correa from Mexico. I was wondering, for the patients with chronic hypoparathyroidism, is there any role for allotransplantation?
For chronic hypoparathyroidism, permanent 6 months following the surgery? 6
months, 12 months.
Well, I think the evidence is that if you autotransplant glands, it takes about 56 days for it to actually take effect. So our definition of permanent hypoparathyroidism is that they require some form of vitamin D and calcium support to maintain normal calcium at 6 months. So at 6 months, when you've actually defined that they have got permanent hypoparathyroidism, the parathyroids will have already obviously died, so I really don't see what the indication in that setting would be.
The question is allotransplantation, saying...
from other people?
From another people, from another person.
I'm not sure how you would do that, really. It's an interesting question. It raises ethical issues, tissue match issues. And as autotransplantation is controversial as to whether it works or not, I'm not sure that you'd even get it through ethics. But it's an interesting thought.
Okay, thank you.
Great, we have another question in the back.
Hi, Dawn Anderson from McGill, Montreal. Silly question, but when you send up people, that was a great talk on the hypoparathyroidism, that was very helpful. When you send people home on vitamin D, calcium supplementation, silly question, how often do you monitor the levels afterwards? Because I've had a couple of patients that were very stable for several weeks, and at some point, a month or two later, again, maybe sudden reawakening of an auto-transplanted parathyroid, they had sort of hypercalcemic crises, and actually one of them went into brief decreased kidney function, which came back once we got her calcium below 3. But I'm just wondering, is that like, was there sudden return of parathyroid? I was very surprised that this happened in 2 patients.
Yeah, you make a very good point. I'm more concerned about the hypercalcemia than the hypocalcemia, because that can easily happen, particularly when you've got refractory temporary hypercalcemia and patients are going home on large doses of 1-alpha-calcidol and large doses of calcium. So in answer to your question, we usually get them back in those cases within a week, a maximum 2 weeks. We again measure their PTH, and that again gives you an indicator as to what's happening, and we get them down on those doses because you do need to see them early. Probably 2 weeks, if you've had a great deal of a problem with them, is too long. You ought to get them back the next week.
I would agree. My general rule is if I send patients home on more than Q-day Rocaltrol, if I send them home on BID, then I need to see them within a week. Because 2 things are happening. One is the Rocaltrol, I guess after about 48 hours, is really starting to become active, and that's also the time frame where your ischemic parathyroids may be shaking off the bruise effect. So, we're anxious to make them better, and we're, mea culpa that we've made them bad in the first place, so we aggressively treat. But anyone with significant vitamin D replacement, I have to see them within a week.
Great. So I'm going to ask a question of each of the speakers. So one of the great things about this meeting is that we have experts from all over the world. So Dr. Randolph, I was curious, at your institution, do you do vitamin D loading similar to what our colleague described? And then Dr. Tolley, I was curious, at your institution, is recurrent laryngeal nerve monitoring routine?
We routinely do recurrent laryngeal for all patients,
Okay.
parathyroid and thyroid.
So vitamin D loading, I get a vitamin D level on all my patients preoperatively, and if it's significantly low, then I load them if I'm planning a total thyroidectomy. The patients where that is most necessary in secondary hypoparathyroidism, I don't know that there's enough vitamin D on planet Earth or enough calcium to really prevent bone hunger. I believe recently the length of stay and the length of IV calcium postoperatively, specifically for that subgroup of patients, is a little bit less long, a little bit shortened by loading preoperatively with vitamin D.
And what would be your threshold? So you check a level, you said if it's low, then you would load.
To get them above 30.
Okay.
But again, I don't think that can prevent even a brief period of IV replacement for those patients with bone hunger, with specifically secondary hypoparathyroidism.
Great. And it looks like we have one more question.
I just want to congratulate both of you because they have really fantastic talks. So I just wanted to ask you about the issue about your loss of signal to proceed to the other side. And this actually obviously caused a controversial issue. Trainees ask you all the time, what's happening with that. So I think it is probably clear that if you use a nerve monitor and you do benign disease, you stop. I think that's probably very not controversial. But if you do a cancer case, perhaps a slightly locally unbiased, advanced thyroid case, you lose signal, and then what are you going to do? Are you going to leave the patient untreated, or what are you going to do? And the second question on that is that whether for these kind of local advanced thyroid cases or cancer cases, you do actually consent the patients for a tracheostomy. And the questions are for both of you. Thank you.
So I think we overestimate our own importance and the morbidity of the disease process and underestimate our risk of complications. And so I think if you obtain monitoring information, you should use it. The International Neuromonitoring Study Group says that as well. I have yet to meet a thyroid cancer that needs absolute contralateral surgery on the same day of surgery. This is what we do. This is what we're used to doing. It's what our forefathers told us. I just think it's not the smartest thing, even in cancer cases where you have to push it. There may be circumstances where that may be the best thing, and it's ultimately your surgical decision, but it is infrequent that a thyroid cancer patient absolutely requires contralateral completion surgery on that day. The risk of bilateral injury in that circumstance, in the setting of ipsilateral loss of signal, is not what you would think it would be, which would be the 1% or 0.5% of contralateral nerve injury. It's much higher. It's more like 10 or 15%. Why that's the case, we don't know in the setting of ipsilateral loss of signal, but my suspicion are two. One is that ipsilateral loss of signal is a rare event, and those are complicated patients, and they may be a little complicated bilaterally. And the second is you're not the same human as you are on that second side in a patient that Neil is operating on, a papillary carcinoma, going to go home that same day. Now all of a sudden you're worried if I nick that second nerve, I'm going to have a tracheotomy tube in this young neck. So you are different, and I think perhaps the fact is the risk of contralateral nerve injury in the setting of ipsilateral nerve injury is 10%. So we have to understand that and behave accordingly.
What about consents for tracheostomy?
I don't talk about tracheotomy. I do talk about the potential for staged surgery based on loss of signal in every patient I plan a bilateral procedure on.
Yeah. I'm not so black and white myself. I'll take a view of how difficult the surgery was at the time and whether the loss of signal is a true positive. If the biology is favourable, if it's favourable cancer, if it's in a patient that they're fit and well, so having a staged operation also is not a problem. then I won't. If it's been very difficult, I will stop there if it's benign or malignant. If it's a patient who's quite sick, it's required a lot of preoperative preparation to get them fit for surgery. The pathology, it actually needs a total thyroidectomy. They may have nodes and they're going to need radioiodine. And if I think it's highly likely to be a false positive, and even if it's positive, I probably will carry on and complete the surgery. Ricard, that's what I'll do. So it's rather than black and white, it's maybe. So I certainly do bail out, and I think we should, because in terms of the UK practice, as you know, in terms of consent, our law has changed from Boland to Montgomery. So the law is now that we have to inform the patient of a complication, even if it's rare, if it leads to a significant and life-altering change in them. And I think we'd all agree that a tracheostomy is a significant change. So if you don't consent for tracheostomy in the UK, they get a bilateral vocal cord palsy, they require a tracheostomy. That is a case that will be settled out of court. And just on the mention of tracheostomy and bilateral vocal palsy, with the big data now, we can now estimate as to what the incidence, at least, of a temporary vocal cord palsy. It's 6.25%. So 2 in 500 patients, and this is consistent across all countries, will end up having a bilateral vocal palsy. 1 in 500 will have a tracheostomy, and 1 in 500 will be managed. They may be intubated overnight and with a bit of steroids, and you'll get away with it. So it's about 1 in 500 that will require a tracheostomy.
Thank you. May I take that argument a little bit further? So let's just say that vocal cord palsy, you stop and you don't proceed, and that patient has got cancer, it's a T3, and you need to complete whatever. How long, and is it true palsy? You do the fiber optic endoscopy the following day, and 3 months is still the same, and 6 months still the same. When you actually make that decision to go to the other side and complete your treatment? Thank you.
So the advantage of staging the surgery is that it's a community that makes that decision as to when to proceed. The patient, the patient's family, the endocrinologist. Some of the cost savings in using nerve monitoring and staging surgery come from some of those patients don't actually ever need contralateral completion surgery. Even though you would have designed it and rolled it in initially, they end up not needing it after discussing with the endocrinologist. So it's a total different and much more informed environment to be able to counsel when you move back in the setting of what you now have found is a permanent or greater than 6 months vocal cord paralysis.
So we're going to have one last question, and then we're going to transition to the panel. So I encourage everybody to stay because we have a great panel talking about surgical complications. So last question.
Yes, Karakos from Greece. You show us level 1 evidence that ligature causes less hypocalcemia comparing with the other techniques. If this the experience of both you experts, what do you think is happening?
I think the evidence is that the use of energy devices is as safe to the parathyroids as the standard technique of clamp, cut, and ligate. So that was the issue. The energy device companies, they often promote that there isn't very much lateral thermal spread. I think we'd all agree, when you are the assistant, you become very aware that these things get very, very hot, because they dehydrate the tissue. The recurrent laryngeal nerve can suddenly come into the field and receive thermal injury. So it's not unreasonable, therefore, that if you're using these devices very close to the parathyroids, then again, that may have a negative effect on them. I'm uncomfortable personally using energy devices really close to the parathyroid, and I don't. But I'm just presenting to you that the evidence is such that it seems, at least on the basis of the literature, that it's safe. But I would be very cautious of using any energy device very close to the parathyroid, because it will dehydrate and thermally injure the parathyroid.
I'll just add one point, is that I think any device that's plugged into the wall whether it's a bipolar jeweler's tip cautery, which is my favorite instrument to use, any device plugged into the wall, if it's on long enough, will start to heat up the area, regardless of what the manufacturer says about 2 millimeters safe, 3 millimeters safe. If it stays on for a period of time, I always like to operate by my fellow and keep my hands close there for a period of time so that I know exactly how hot that tissue is getting. So, and you know, with the harmonic at least, sometimes that tissue divides very promptly. Other times it goes and goes and goes and goes for reasons that are unclear to me. Level of hydration of the tissue, amount of fat, tension on the tissue, factors that go beyond my comprehension. The bottom line is, for jeweler's bipolar tip, you know, the finest tip instrument that I have that divides tissue through cautery, I do it 3 seconds and stop, whether the tissue is divided or not. There's a real tendency, though, you want to divide that tissue. You want to divide that tissue, and you just keep it on until the tissue is divided. But if you learn to stop and behave yourself, and after 3 seconds or some short period of time, stop, I think it's much safer to use all of these devices.
Great. So I'd like to thank both of our speakers. They did an excellent job. And then I'd like to invite some of the panelists to come up. We have an exciting next session on surgical complications.